Hello and welcome everybody to tonight's webinar. My name is Dawn Davin and I'm going to be acting as facilitator to tonight's webinar. So the title of this evening's presentation is Diabetes and Overview. We've got fantastic speakers lined up. Who are going to talk to you about sick day guidance. We're also going to have some information on lower limb health. We are also going to have a third speaker who is going to look at Trevor, who's going to look at the role of the pharmacist and medication reconciliation in the setting of diabetes. And we're also going to have a session or sub-session on self-management, education and support. So if you're joining us from Dublin, thank you very much for choosing us over the sunshine. And if you're outside Dublin, I hope you've got an equally nice evening wherever you are. So just some housekeeping rules. This webinar is being recorded, as you've probably seen. If you're having any problems with your sound, you'll note that your microphones are muted, and we'd ask you just to keep your microphones muted throughout. You can leave your videos on or off as you wish, but if you're having any problems with your connectivity, we would advise you just to turn off your video. That can often help. And if you're having any problems with sound, similarly, just to make sure that your speaker, you can on and off your mute, but as I say, we will keep it muted, or make sure you have it turned down yourself on your own computer, especially when it comes to the Q&A at the end. If all else fails, try the old reliable of logging off and logging in again, but please do feel free to put a message in the chat if you're having any problems. We will use the chat box for questions and comments, and I imagine there'll be lots of questions tonight or comments, so please do get those questions in and we'll address them at the very end. And we may use some anonymized information from the webinar tonight, just to let you know. So without further ado, I'm going to go through our 4 presenters tonight, so thank you all for your time. So our first presenter is Joanne Lowe, diabetes nurse specialist and nurse lead with the National Clinical Programme for Diabetes. And Joanne is going to speak to us on medication and sick day guidance. Assumpta Coyle, who's podiatry manager in the Saolta group and podiatry lead from again at the National Clinical Programme for Diabetes. Trevor Hunter, who is a primary care pharmacist and pharmacy rep on the National Clinical Programme for Diabetes Working Group in the HSC. And finally, Dr. Ciara McGowan, a senior dietitian and self-management education and support office in the HSC. We may just have a problem with connectivity for Assumpta, so it may be the case that Assumpta is presenting for us, but we'll let you know as we go. So without further ado, I'd like to hand over to Joanne to kick off tonight's webinar. Thank you.
Thank you very much, Dawn. Thank you for having me this evening. Grace is just going to share my slides. Thank you, Grace. So as I say, I'm Joanne Lowe and I'm clinical nurse specialist in diabetes, and I work with the National Clinical Programme as well. Next slide, please, Grace. Just want to talk about what happens to people with diabetes when they become unwell. So we know that if people living with diabetes get illness, infections, other forms of stress, that their bodies will release hormones to fight this illness, which can lead to a rise in glucose and ketone levels. And people with diabetes don't always have enough ability to produce insulin to cope with this change. There may be other illnesses as well, like vomiting or diarrhea, that lead to hyperglycemia. There may be risk of dehydration. And we know that this can lead to poorer outcomes and increased hospital admissions. Indeed, this is just a headline from last week, talking again about the impact, the disproportionate impact that COVID had on people with diabetes and problems they're still struggling with at the moment. So with this in mind, the National Clinical Programme has put together some guidance for people living with diabetes and for clinicians as how to cope at times of being unwell. Next slide, please. So we have 3 national resources available for adults living with diabetes. We have the first one on managing type 1 diabetes at times of being unwell, managing type 2 diabetes at times of being unwell, and they're patient-focused leaflets. And then we have another information leaflet on managing type 1 and type 2 diabetes, and this is advice for the clinicians. Next slide, please. So why did we do this? This is the first time that the National Clinical Programme has undertaken this piece of work. So it was a big thing. It was a big deal to get this, to get the consensus, to get this across the line. What we've done with this first version is to look to other places for their experience. So we look to Trend UK and the Primary Care Diabetes Society to look at documents that they produced previously and to learn from their experiences. So it took us around 3 years to nationally agree these guidelines for an Irish setting. It's really there to standardise management of issues that can occur at times of illness. And also as well, recently, there's been a massive increase in therapies available for diabetes, and there are issues that people living with diabetes need to be aware of. We also want to provide guidance on when to escalate care and, if possible, avoid potential hospital admissions. And we also wanted to provide a point of reference for clinicians who don't have diabetes as their speciality. Next slide, please. So just to give you a brief taste of what's in each of the leaflets, in the leaflet for type 1 diabetes, we talk about self-management when unwell. We look at blood glucose and ketone monitoring, food and fluid replacement, insulin adjustment, recognition of emergency situations such as ketoacidosis and hypoglycemia, when to seek help. Just to note with this one that there isn't a version of this yet available specifically for people using insulin pumps. This is just a general leaflet, and that's something that we'll probably look to develop in the next iteration of these guidelines. Next slide, please. If type 2 diabetes, again, it's a similar type of thing. We talk about blood glucose monitoring, management of oral medication, management of injectables, GLP-1s and insulin. Again, recognition of emergency situations. We've included the hypos, but also as well the possibility of euglycemic ketoacidosis, which can occur with the SGLT2s. And again, where and when to seek further help. Next slide, please. And then, as I say, we have a other document, which is advice for clinicians. And this advice for the clinicians covers type 1 and type 2 diabetes. And again, a variety of information, which includes safe adjustment of insulin and, again, managing those emergency situations. And you can see just a couple of examples there. We talk about general advice for management during intercurrent illness. So looking at glucose level, insulin, carbohydrates and ketones. And then we have the SADMAN rules as well, which I'm sure is something that you're all aware of. Just a medication that might need to be stopped during times of illness. So that's there as a reference point for you all. Next slide, please. Thank you. So the role of the pharmacist is obviously, as I don't need to tell you, very, very important for our people living with diabetes, and particularly when it comes around education and advice. The regular contact that you have with people, the enduring relationships that you build up are just such an important point of contact for them. And also as well, for people with diabetes, there are very likely points to come to during early times of illness. So maybe they're coming in for over-the-counter treatments or for maybe they've just come from the GP with their prescription for their antibiotics. So this is an absolutely perfect place to highlight that this information is available to them and be of assistance. You're also in the perfect position as well for other types of health promotion, such as vaccinations. Again, this is stuff that you are much more aware of than me. So just to say, where can you find these resources? We didn't print a paper version of this, and all the resources are available on the National Clinical Programmes website, which is part of the HSE website, under resources and education. So that link can be shared with you. And what I do is just keep those on my desktop, and then I print them off. And when I'm using them, I try to do an individualized chat depending on what medication the person is taking. Obviously, say this is the first time we've done this, and we're really keen to get your experience and from people living with diabetes about how you find this information. Is there anything that we could do better? Is there anything missing? Or is there anything, as I say, that you would like for the next version? So any feedback to the clinical programme would be welcomed. Next slide, please. So thank you very much. That's just a short presentation, and I'll take questions at the end. Thank you.
Thank you very much, Joanne. And now I'm going to hand over to Assumpta. She was having some connection details or problems at the start, I should say, but she's managed to log on. So I see Assumpta there. So thanks, Assumpta.
Thank you, John. Can you hear me okay?
Yes, we have you. And there's the start of your slides, Assumpta.
Thank you very much, John. And to all of you on the call tonight for your time and for your invite to join you this evening. My current role is as a podiatrist, specializing in care of the patient with diabetes and diabetic foot disease. And I'm part of the National Clinical Programme for Diabetes team. Next slide, please. So just for the first 1 or 2 minutes, I just want to step back really quickly in relation to Saolta care. You're all very aware of this, the fundamentals of Saolta care and the whole change around within the HSE. And multiple publications that have actually changed the structure of how we're actually working within the HSE within the last few years. I see Trevor is with us tonight, and Trevor has worked for many years on the National Clinical Programme Working Group and has listened to Podiatry's changes over the last 4 or 5 years in kind of restructuring how care has been delivered. But that restructuring really has actually affected multiple services and multiple designs across the country. So next slide, please. So I just wanted to kind of reiterate that backwards in the viewing of where we are sitting. So Dawn has advised me that there's people from across the country on the call with us tonight, and you'll know previously the HSE divided its service into community health areas, which was the previous arrangement. Under new Saolta care, these geographical locations for service delivery is going to change. Next slides, please. And we will be working towards health regions per se, and there'll be 6 health regions which will provide population health. Each health region will be further divided into networks, and then networks will be supported by chronic disease hubs. So we'll have end-to-end care community services, which will be all community services, including GP, pharmacists, all of the kind of direct contacts, and the hub, which will be the clinical specialist teams for diabetes, which will be nurses, dietitians, and podiatrists, will be set up and are currently in their 3rd year of being set up within community settings, and then acute services, with the idea of taking the highest complexity patients only towards the hospital system, having very highly specialist people within community settings within the hubs, and obviously direct contact with the GP to the community hub teams, and then directly into hospital. Next slide, please. Within each of the regions, a hospital group will support each of the actual regions, and there are 7 hospital groups which will be slightly changing their structure as time goes on. But for each regional health area, a hospital group will support those regions. Next slide, please. And I think the reason within Saolta Care is they wanted to change and restructure how care was being delivered. I'm not going to go into the details of integrated care, and I just really wanted to spend that first minute or two kind of taking us back in relation to the restructure within the actual HSE. So we're gone directly towards population needs, and complexity. So the highest complexity only being taken to the hospital. So greater care being delivered within the community setting and closer to the patient's home. Next slide, please. Within the chronic disease programs, we are one of an integrated program in the National Clinical Program for Diabetes, and that's what I'm going to concentrate. But just to say that there's also cardiovascular disease, COPD, and asthma, which would have specialist teams being developed over the last couple of years within the community setting to support community. Next slide, please. Within the chronic disease programs, we have a model of care for chronic disease, which is a framework for Ireland for the integrated prevention and management of chronic disease. And that is halfway through at the moment, where we have the specialised teams in the community to supply specialist support to the GP, providing end-to-end care for patients diagnosed with and I want to concentrate on diabetic foot and diabetic foot disease. So the foot protection team is situated in the community setting, and the multidisciplinary team is in the acute setting. Next slide, please. And I'm sorry, this is just a specialist overview of what has actually been resourced in the hub. So within the actual hub setting, the specialist team will support 3 networks of a population of about 150,000 people. And they will provide kind of that greater level of specialty outside of the hospital walls. Next slide, please. So coming from there, really what I wanted to just quickly focus on was the patient diagnosed with diabetes and foot disease. And again, the care of those patients is divided into the regional health areas. So teams, specialist teams are now throughout each county, for example, Galway, Mayo, Roscommon, Sligo, Leitrim and Donegal, and each county thereafter would have specialist teams supporting approximately 150,000 of a population. Next slide, please. Thank you very much. Within the chronic disease model of care, one of the areas that was concentrated on was the diabetic foot, and the model of care to standardize care for patients living with diabetes and diabetic foot disease was published originally in 2021 and restructured and redesigned in 2021 and published. And it was published under the chronic disease program, really to provide standardized care across the country with clear roles and responsibility for diabetic foot care. Next slide, please. Within the model of care, the call is for all patients to receive lower limb health and foot screening. This foot screening can be carried out by any of the member of the GP practice or the chronic disease specialist team or any of the hospital team. Each lower limb will go through a series of short screenings. The result of that screening will, the outcome will give a classification for that foot, either be a low risk, which means it'll be in the normal ranges, normal blood supply, minimal foot deformity, no skin break, no damage to the neurological system. And from there, we would go to moderate risk, high risk, the in remission, and active foot disease, with active foot disease being a current foot ulcer, spreading infection, critical limb ischemia, active Charcot-arthropathy, and the new classification, which is in remission, where a patient would have had a previous foot ulcer that is now healed, or a previous amputation site that is now healed, or a previous Charcot-arthropathy, which is now not active. Within the new model, the patients diagnosed and classified their lower limb as low risk would be reviewed under the chronic disease model by the GP practice. The moderate, the high risk, and the in remission foot would be the responsibility of the diabetes team within the community hub setting, and the podiatrists that work within that team would lead on that care. And the patients diagnosed with active foot disease would be the highest complexity foot and would be treated and referred immediately to the hospital setting. Next slide, please. Thank you very much. So within the model of care, we're calling for really and truly standardized care research over a decade within the Irish setting from 2011 to 2020 had shown us that standardization of lower limb health for patients across this country was very ad hoc. So the screening program that is now being rolled out across the country, and the management plan for patients with either type 1 or type 2 for lower limb health to be standardized by all the teams. And I won't go into the details of each section, but within general, we have the community foot protection team in the community and the hospital multidisciplinary foot team in the hospital, and we would have the general practice within the community setting with the endocrinology team looking after the low risk type 1 diabetic foot screening. Next slide, please. This is when I was asked to partake in this, I still perform a MDT clinic within the hospital in the west of Ireland in the Saolta Hospital Group. And I decided, just as a little questionnaire for myself, patients that would come in, because I've known myself from working directly with patients, that the pharmacists or the chemists, as a lot of the patients still like to refer to, patients would often arrive in to the pharmacist with a foot problem or looking for direction or help in relation to a foot problem. So I just took it upon myself to ask my colleagues and some of my patients over the last couple of weeks, when you notice this problem, or did you ever talk to your pharmacist about it? So these were the answers I got, which I thought were quite interesting. And this is just over the last couple of weeks. There was a lady who was coming into us, was finding it difficult to follow our regime, and had said to me, I got the dressing. I do the dressing myself. I got it wet, so I got some new dressings from the chemist woman. The second lady said she came in with all of her toes, she was trying to protect them, so she had plasters on them. Her daughter-in-law had bought her some new shoes. I noticed she had plasters on. She said, I went in to collect my tablets and I got some plasters for the little cuts off the pharmacist. A gentleman told me that he took his sock off in the middle of the chemist to show the man his sore foot when he went into town. And I thought these were very honest, because I can just imagine some of our patients doing that across the country to some of the pharmacists that would work across the country. To my colleagues, I had just basically said, I was doing this talk tonight with you kind of briefly, and would they have anything that would kind of be on their tip of their tongue? My colleagues have basically said the patients will always or usually speak to the pharmacist about foot and skin products to begin with. Diabetic foot education was one of my colleagues said the pharmacists were very good in her local town at giving them direct education and downloading some of the resources from the internet, which I'll go through with at the moment. Another colleague said patients have advised me they'd often ask the pharmacist in their town or their team where they could go for certain services. And my other colleague from Cork said, fantastic first line contact in communities for many patients with foot problems, especially outside of the cities. Next slide, please. So I just thought that was interesting just to pop in. I just said I'd find it. One of the slides I just wanted to pop in here, which I thought may be beneficial to all health workers that provide any level of care, is the HSE area finder. So every single patient that would know their postcode they can pop their postcode, or if somebody asks you a query in relation to their you can put in the HSE area finder, you can put the air code into it belong to the patient, and it would actually bring up all of their networks, their nursing services, and their chronic disease hubs that are actually affiliated with that postcode, and where their services would actually be to support them. Next slide. And this is just one of the slides I would like to direct you towards. So for patients diagnosed with diabetes and living with lower limb foot disease, it is, as you know, I don't need to explain the details of diabetes. It is whole body encompassing. And by the time patients actually have active foot disease, it is usually a sign of multi-organ disease. Patients would ask many healthcare professionals for direction either on products or on kind of general care, or even corns or callus or cuts or sores in their feet. In relation to patients living with diabetes and lower limb, I think one of the most important things to actually remember and understand is the level of neuropathy and lack of sensation in these patients. And though they may feel very, very little, they will tell you everything is fine. So I suppose the main thing for me is just to guide people towards resources, or some resources that may actually help anybody working within a pharmacist situation if they're unsure of maybe where to guide people. There's obviously the diabetic retina screening. There is the HSE resources on the A to a Z of the HSE site, which covers, and I know Joanne has spoke to about this already, but it is really a lot of the information in relation to how to look after their lower limb, just kind of general care of their skin and nails, and like Joanne said, details on diabetes specific, pre-diabetes, diabetes and pregnancy. There's multiple resources available on HSE land. Next slide, please. And just a kind of a last slide. Under the umbrella of HSCP is the profession of podiatry, as are dietitians and multiple other HSCPs, from physiotherapy to optometry to psychology. And CRU over the last few years has become our regulatory body, so we're trying to get that message out to health professionals across the country, that obviously Ireland supports regulated professions, and CRU regulation is what health and social care professionals are now registered under, to include podiatry. Next slide, please. And really and truly, I suppose what I just wanted to do tonight was just show you a little bit of a piece in relation to the foot services, how the direction of travel has changed, how at the moment, over the last couple of years, we're going through a complete restructure in relation to services. Do we have challenges? We definitely do. Finding podiatrists across the country can be a challenge to keep them within the health service. We have the private sector and people traveling abroad. But I just really wanted to give a kind of an overview of where we are in relation to diabetic foot at the moment.
Thank you so much, Assumpta, and thanks again for meeting the many challenges you had with getting online. We really appreciate your tenacity. So next I'm going to hand over to Trevor, please.
Okay.
There we are.
Okay, so thanks very much for inviting me to talk. I would say I'm on the National Diabetes Group, and I would really like to thank Joanne and Assumpta for two excellent presentations, which really demonstrate how a pharmacist can interact and be a first point of call for patients in terms of advice and education around their medications, sick day rules, and also the foot. So I'm not going to talk about those sort of areas, and I won't cover everything, but I just wanted to talk about medication safety in diabetes. And two areas I wanted to talk to was about medication review and then some medication safety issues and tips around insulins and SGLT2s. So there was an excellent presentation, the first in the series back in April, and Lisa Devine produced a fantastic slide about the complexity of type 2, people with type 2 diabetes. And they're just a small cohort. You have 3 groups there, the older ones with good functionality and without complications, all the way to people with multiple more comorbidities and cognitive dysfunction, and how you treat each of them differently, and the goals, and that also goes for their medication. So medication review is around these is quite complex. And when we talk about medication review in diabetes, we're not just talking about diabetes, because so many people have like COPD, or they have cognitive impairment. So it's quite a big task. In terms of medication review services in this country, in terms of being remunerated, there are very few that are. The first one would be under the chronic disease program. We have like review by the GP and nurse, and this has patient interaction, but these are actually quite short consultations. I wouldn't be really holistic, because they may be focused on the diabetes medications. Community pharmacists under their contract review medication and prescriptions before each dispensing. And this maybe is like a medication list initially. A more complex and a better one would be a medication usage review. And this is common in other countries like in the north and in Scotland, but is yet to be mainstreamed here. Now, 2 interesting developments that are coming down the line are medication reviews in PCRS and the iSympathy polypharmacy review. So in development is medication review by PCRS pharmacists. A number of these have been employed under the 2019 GP contract. And as I say, it's in development, but the GP will be able to refer complex patients to PCRS, and they will look at the they will provide information on medications, comorbidities, recent bloods, other clinical notes, and the PCRS pharmacists will have the advantage of being able to look at the pharmacy claims data to get a more total picture. So this is in development. There's likely to be a pilot at the end of this year, beginning of next year. So that's something that's really going to benefit patients. In terms of a holistic MR3 type medication review, the ideal is that you have your patient with you. You find out what's important to them. They want to be able to walk to the end of the block. They want to be able to collect their grandchildren from school. They want to be pain-free. And a holistic review is important in terms of having access to the medication list, what the clinical markers are, having an up-to-date diagnosis, indications for each drug. And this type of project, or this type of intervention, was illustrated and delivered in the border regions by the iSympathy project, which ran from 2020 to 2023. And if you haven't heard of iSympathy, you should have a look at the evaluation report and the main findings, because it really showed the benefit of really good pharmacist trained, pharmacist skilled interventions. And this had an outcome of being improving the quality adjusted life years by about 7 on average per patient, which is an absolutely amazing outcome. And it was pretty much self-funding, and we're waiting now to see, will it be mainstreamed? So like that will obviously have resource implications. But this type of project, there have been IIOP webinars showing the intervention, but it really is the way forward in terms of patient care. So that's a bit around medication reviews. And now I just would like to talk about a few cases in terms of medication safety issues. And the first one I'll just talk about would be insulin. So insulin is the fourth most commonly indicated pharmacological subgroup in terms of medication incidence. A lot of this information is gathered by the NIM system, the National Information Medicine System. Now, this is actually goes through the hospital sector, community nursing units, ambulance services. It doesn't actually gather information from community pharmacy or through GP practice, so there's a bit of a gap there. But like you can see, there are 20,000 medication incidents in 2017, 2018. And then looking abroad, looking across to the UK, 40% of hospital inpatients experience insulin dosage errors in one study back in 2019. So insulin is really high up there in terms of risk. So what are the types of risks with insulin? Well, you have your high strength insulins, which I'll go on to in a second, but other types of errors are, it doesn't sound logical, but there was one case in the UK where a healthcare professional extracted insulin from a cartridge and put it into a insulin syringe, and it was 500 units per mil, and the syringe wasn't graduated in 100 units per mil, so the patient got a 5 times overdose. One other area that in the past has come up is using the same insulin pen for different patients, and using different needles, but there's huge risk here from cross-contamination with, I think something like one study showed 40% had contamination with epithelial cells from one patient to the next. So this is quite a serious issue. And finally, we have prescribing and dispensing errors. So the Irish Medicine Safety Network, who are a really fantastic organization in terms of producing very good practical leaflets and guidance. They looked at the high strength insulins, and years ago, everything was 100 units per mil. But now, because we have Tresiba 200 units per mil and 2J 300, there's a huge risk of errors, doubling or trebling the dose. So the Irish Medicine Safety Network have brought out information leaflets to look at safe prescribing. One of the big things with the insulins are that they should be prescribed by brand name and strength, and that you use the word units on the prescription, not using U or IU. And where you have, say, Tresibas, you would circle 100 or 200 to make it clear what the strength is. In terms of providing supply, storage, and labeling, all insulin cartridges and pens should be on a named patient basis. Should be no sharing. And then in terms of administration, there should be checks of the brand and strength against the insulin prescription, and only administer when the pen device with the appropriate needle is attached. One important factor is a patient factor, in that many patients, as you know, will have retinopathy, and if there are any issues in terms of their visual acuity, some of these products will not be suitable. Like Tresiba dials up in 2-unit increments. So if they're thinking that every click is 1 unit, they're going to get a doubling of their dose. One source of error in terms of insulins is similar sounding names. And there's a list of the most common ones. I have a particular thing about the Humalogs and Humulins, because I think they're very badly named. And I've had, in community, I've had a couple of cases come to my attention. One of them here was where a patient was prescribed 40 units of Humulin M3, long-acting insulin, The patient noticed that the insulin was clear, which was kind of unusual. And then, of course, their blood sugars were erratic. And then they looked at the pen and discovered that it was the wrong one they got. And in the second case, the diabetes nurse specialist was adjusting insulin based on the assumption that the client was taking human M3. This patient had unresolved postprandial hyperglycemia, and the insulin seemed not to be working, and despite strict stringent dietary changes. And then the client was asked to report the insulin name to discover it was human I. So this error came about because there were different sources of information in terms of prescriptions. There was a GMS prescription in July 2018, whereas the pharmacy had been working off the client's LTI book, long-term illness book. Now, thankfully, with the advent of Health Mail and the fact that you now only have an LTI eligibility, this type of error should be a thing of the past. So those are just the points about insulins. I just want to talk briefly just about the SGLT2s. Lisa Devine in the presentation in April gave a very good talk on the different the newer drugs. But the SGLT2s, they're big there now. They've replaced, say, metformin in some cases. They're protectant in terms of heart failure and also for kidney function, but they do have issues. And this is just the SPC for dapagliflozin. And you can see, like, very common, you have like hypoglycemia with sulfonylureas or insulin, and then genital infections, either bacterial or fungal, are quite common. And I think this is an important point to know in pharmacy, that when somebody presents to you for, say, a thrush treatment, and particularly if it's what do you call it, common and they repeat, to ask them, well, what medication you're on, and to see if there's an SGLT2, because this could be the issue. There's also this rare condition, diabetic ketoacidosis, and because SGLT2, like diuretics, they basically flush sugar and water out of the system, people are prone to dehydration. And this can be an issue for patients coming in for hospital procedures, for surgery or invasive procedures. And actually, the Bon Secours in Limerick have produced a very good safety of leaflet about the importance of stopping the SGLT2s 3 to 4 days before an invasive procedure, because of this risk of the euglymic ketoacidosis. So that's an important factor to consider when you're talking to your patients, and they should really resume these SGLT2s when they're stable in eating and drinking. Okay. So in terms of medication safety, what can health professionals do? I think it's very important to record safety incidents. It should be used as an education tool. Identify what were the contributing factors. Schedule regular safety meetings to educate all team healthcare professionals. And there's a lot of really good information there. The Irish Medicine Safety Network, the National Medicines Information from St. James's, HPRA on terms of best practice safety alerts. Display insulin charts and solids for easy reference. And finally, to ensure insulins are included in medication lists for no check ask, because sometimes you'll have, people have had their list, they printed off from their PMR, but if the patient's on a low dose of an insulin, it might be 2 months, 3 months behind, and it mightn't be picked up. So it's important to include that with this no check ask. So, and thank you very much for listening. I'll take questions at the end of the session.
Okay, so good evening, everyone, and thank you so much to the IIOP for inviting me to speak today. So I'm going to be talking about self-management, education and support for people living with type 2 diabetes and pre-diabetes in Ireland. My name is Ciara McGowan and I am a senior dietitian working in the self-management, education and support office. And we sit in the integrated care programme for chronic disease, as Assumpta made reference to in her presentation. I could probably talk about this for probably an hour, so I'm going to squeeze a lot in the 10 minutes. And I apologise for some busy slides, but you'll have them for reference after this evening. So we know that living with a long-term condition is not always easy, and 99% of diabetes management is actually self-management. So you are very lucky if you get to spend 3 hours with a healthcare professional on any given year with diabetes. So you're left to self-manage your condition for the remaining 8,757 hours. We also know that there's a lot of people living with diabetes in Ireland, and there's even more people at risk of developing diabetes. And self-management education and support has been listed as the cornerstone of clinical care for people with type 2 diabetes from our most recent model of care in 2024. So what is a self-management education and support program? We call them SMES programs for short, and then we call them diabetes support courses for members of the public. So they are any form of education or training for people living with a long-term condition that focuses on helping them to develop the capability, the self-efficacy, and the confidence to effectively self-manage their own health. And we use this analogy of the car. So the person living with the long-term condition is the driver of their car. And we as the healthcare professionals are guiding them, we're giving them guidance and support, and they're the ones that are actually taking control of the journey that they're taking. And we know that life has many bumps, but living your life with a chronic condition has even more bumps along the road, and often people will need self-management education and support at various times on their journey with something like type 2 diabetes. To be called an SMES course, there has to be 5 key standards or key criteria in the programme. The first one is an underpinning philosophy of care, such as behaviour change, the empowerment approach to care, the patient-centred care. There also must be a structured curriculum. There must be trained educators, audit and quality assurance. So these must be present in order to call your programme an SMES programme. I'm going to talk a little bit about what courses are available for people with or at risk of type 2 diabetes. I'm going to focus on the 2 HSE owned programs, which are Discover Diabetes Type 2 and the National Diabetes Prevention Programme. But we also have 2 other wonderful programs available for people in Ireland. And the first one is called Desmond, and it's a UK course, but it's HSE endorsed, and it is an in-person and online programme which offers 6 hours of education and support, usually delivered over a full day or 2 half days. And this is primarily delivered in person in Ireland, in the northwest, in Donegal, right down to Galway and parts of Limerick, as well as urban areas in Dublin and some urban areas in Limerick. And then Diabetes Ireland also have a programme called Code, and this is run online, and it offers 8 hours of education for people with type 2 diabetes, and it's 3 sessions over 3 weeks with a follow-up session at 6 months. So just to delve into the first programme, which is the Discover Diabetes Type 2 programme. So this was developed in 2019, and I had the privilege of being on that working group who developed the programme and piloted it in Cork and Kerry and Kilkenny and Waterford in 2019. It was developed as an in-person programme, but thanks to COVID, one of the only good things that came out of COVID is we now have an online SMES programme for Discover as well. And it offers 15 hours of education and support, and it's delivered across the different CHOs from CHO 3 all the way to CHO 9, and it is Kismet accredited, so it's a QA. We achieved QA accreditation just last year. What it looks like for a participant or for a person living with type 2 diabetes. So the core sessions are 4 weekly sessions of 2.5 hours with follow-up at 6 months and 12 months. And if a person is joining an online program, the sessions are just a little bit shorter. The core sessions are over 6 weeks and then a follow-up at 6 months and year 1. just to go through some of the content of the program. So there's lots of different topics over the course of the 4 or 6 weeks and over the course of the whole 12 months. So there's a big focus on what is type 2 diabetes, what's happening in the body with type 2 diabetes, and the relationship between food and type 2 diabetes. We also cover things like the possible health problems that people might encounter when they have type 2 diabetes. We look at an individual taking ownership of their own diabetes by encouraging them to learn what the numbers of their blood tests mean. So we have simple messaging like the ABCs, so the A1C for A, the blood pressure for B, and cholesterol for C, and knowing what those numbers mean and having the confidence to talk to their GP or their practice nurse about these numbers. We also have a huge focus on behaviour change, and that's a core component of every session, and looking at different treatments that work for type 2 diabetes. And really these participants are on a journey of discovering what works well for them, and they have time over the different sessions to make changes to their lifestyles that are meaningful for them, whether it's changing food habits or moving more or taking on another exercise or quitting smoking, or taking the medicines as they're prescribed. We also have a lovely session on minding our minds and managing stress. And obviously, you know, diabetes distress is quite common among people living with diabetes, so it's a really important element of the course. And my plan for change. So people are encouraged to make plans for change, and there's a lot of reflection and peer support in the groups. And the course is integrated with all of the different services that are within the HSE, as well as just the general communities around the country. And these are just some nice images from some of our recent groups this year, and just kind of a flavour of what a room would look like if you were attending a Discover course. So we audited, we completed a pilot of the Discover program back in 2019, and what that consisted of was there was 12 core courses at baseline, and these were delivered between March and May 2019, with a 6-month follow-up session later in 2019. And of course COVID kind of threw a spanner in the works then. Our year 1 sessions were a little bit different to how we envisioned back in 2020. There was lots of different components to that audit, but just to kind of give you the high level overview, so we had 180 people with type 2 diabetes who registered for those 12 courses, and we had an age range of between the late 30s all the way up to people in their 80s attend, with the mean age of 63. And lovely to see more men than women attending, so just over half of the group were men and less than half were women, and more than half actually had their HbA1c within target, so less than 53 at baseline. And just out of interest, 2/3 of the group were living with obesity. We had great levels of engagement generally from all SMES courses around the country. Once people come to the first session, they generally tend to stay, so it's really, really encouraging. Excuse the busy slide, but we saw significant clinical changes for the group. There was significant reductions in HbA1c, and these were sustained at both 6 months and year 1. The writing in bold is the change in HbA1c and weight for those who were out of target at baseline. So we saw even greater changes in HbA1c levels in those who had an HbA1c over 53 to begin with. There was also a mean weight reduction of 3.5 kilos, and this was sustained at 6 months and year 1. And there was a trend of greater weight loss over time in those who did lose weight. And I suppose most importantly, the feedback that we got from the participants, and since our pilot, the participants' feedback has been invaluable to our learning. Everyone seems to really, really get an awful lot from attending an SMES program. So I'm just going to throw out a few words from some of these comments. So all the sessions were full of interesting information, mind changing on diet, exercise, medication, care of feet, care of eyes, taking the fear out of diagnosis, health results and understanding them, huge benefit. And the atmosphere in the group was excellent, and group participation was helpful. And getting to meet other people living with the same chronic condition as you is, I suppose, one of a highlight of attending an SMES course like this. We also looked at diabetes distress, and I'm not going to delve into this too much, but we were really happy to see that the reported diabetes distress using the paid 20-question validated questionnaire, the reported diabetes distress in the severe category was over a quarter of the group at baseline, and thankfully this significantly reduced down to 14% at 6 months. Some of the top 5 concerns that people report when they have diabetes is worrying about the future, worrying about the possibility of complications, feeling constantly concerned about food and eating, feelings of guilt, feelings of deprivation, and not having clear and concrete goals for their diabetes care. Moving on swiftly then to the diabetes prevention program. So this is an SMES program which is modelled on the DPP internationally, and the evidence for the DPP internationally is that it should be a course of longer duration with frequent contacts. So it's designed as a 12-month package of care with 14 sessions over that 12 months, with an individualised dietitian-led initial assessment, a medical nutritional therapy and care plan at the outset. It was designed in 2020 in Ireland by a group of dietitians, and it was initially proposed to be an in-person program, but because of COVID, we had to design it for online delivery first, but it's now being translated for delivery in the in-person setting. What it looks like in terms of the participant journey. So after that initial assessment and the participant is joining the groups, there's 6 weekly sessions of 1.5 hours, followed by 8 monthly sessions over the 12-month period. So it's a full 12-month package of care, and then the person is referred back to their GP. The curriculum has 4 pillars. So eating for health, movement for health, change for health, and weight for health. And there's different topics within each of these pillars within each session. And just to look at some of the pilot results from the National Diabetes Prevention Programme, it was completed in 6 CHO areas around the country with 73 participants. All had their A1C within the 42 to 47 millimole per mole range. Just over half the group again were male, and the mean age was 60, but again, a huge range from 35 up to 82 years of age. And these were people that were all logging on online. So the older people who were attending this pilot program had no difficulties with the technology, and it was delivered by trained, experienced dietitian educators. And again, similar to the Discover pilot, we had really high levels of participation and really positive service user experience. People reported increased knowledge, improved skills at shopping and planning for healthy food, and improved confidence, and overall really satisfied with the program. I suppose one of the most important clinical findings at the 1-year point was that 50% of the group returned to normoglycemia. We also had nearly 3/4 of the group who had lost weight, and with a 5.5% weight loss in those that did actually lose weight. And we know from the evidence that losing 5 to 7% of a person's weight can really help prevent type 2 diabetes in the future. Some of our developments for the next year or so: we're hoping to scale up these programs for full reach across all CHO areas. We have the diabetes prevention program commencing in CHO 2 and 4 this year, which is exciting. We will be offering both online and in person. So online is here to stay, but most of our courses are being offered in in-person setting at the moment, but we'll be offering both. And the DPP is being adapted for women who've had gestational diabetes as well. Just to finish, I suppose, what you can do as a pharmacist, I suppose you're meeting people with type 2 diabetes quite frequently. So if, for example, if a person with type 2 diabetes is starting on a new medication, it might be worth asking them, have they ever attended a diabetes support course? And if they haven't, directing them to the website that they can actually self-refer. So people living with type 2 diabetes can self-refer to the free diabetes support courses, and this is through the HSE website. Otherwise, they can be referred via their GP, and this is regardless of their GMS status. They have access to these courses for free. And I've included a link on a course information video here as well, and also the A to Z of diabetes on the HSE website. And just to say as well, our Healthy Eating for People with Type 2 Diabetes booklet was translated into 12 different languages just in the last 6 or 12 months. So they are a great resource for any people who come into the pharmacy who don't speak English as the first language. And then if you have a person with pre-diabetes, people diagnosed with pre-diabetes can be referred to the free diabetes prevention program via their GP. So it's directing them back to their GP, asking them to talk to their GP to see if they can refer them to it. It's generally a quick link on their health link drop-down menu. And again, it's regardless of their GMS status. They cannot self-refer at this point because of the GP contract with the chronic disease program. There's also a link here to the promotional video for people at risk of type 2 diabetes that you might like to watch. And we also developed a new patient booklet, and this can be ordered for free or downloaded from healthpromotion.ie and might be something else to be able to give out to your patients with pre-diabetes. So that is it. Thank you very much for having me present. I'm happy to answer questions.
Ciara, thank you so much. I think that expression, it's a marathon, not a sprint, could be used both ways. Clearly, our presenters have so professionally sprinted through so much material to talk about the condition that we know is a marathon for patients, which is diabetes. I'd just like to say before I go to the chat box, I know we're slightly over time, but I'm just going to take 1 or 2 questions because I think it's so valuable. We will collate all the links that have been put in the chat box and included in our references that will go up on our website, just if you haven't managed to catch them. A big thank you to Kathy. She's been very busy in the chat box adding links as we go, as has Ciara, so thank you. So I just want to flag for anybody who hasn't been following the chat box, Kathy has put up links to the diabetic foot care booklets, to the sick day booklets and where they can be accessed. And I would really encourage everybody, as Joanne has said, to feed back with their experiences or suggestions on the sick day rules. There's also, information being put up on the module called Victor, which is coming out next year. As I've read your comment, Kathy, in regards to Daphne, a lot of questions on Daphne, which I'm going to come back to in a second. And also Trevor on iSympathy as well. The link has been put up for anybody who wants to read more about the iSympathy pilot. So I think just 2 comments before I go to the chat. Fantastic to see how patient-centered everything is. And both Ciara and Assumpta, you've captured that in terms of the patient comments very specifically tonight. And I also think some of the learnings, for example, the HSE area finder, where you can find further information. And I know the National Clinical Programme for Diabetes has a huge repository of resources as well. So if I could, I'm just going to the chat box. I'm going to take one of the questions that has come in here. If I could ask somebody to take it, maybe in terms of a theme, if you like, of referrals and how people get access to information. So are there any plans to encourage the uptake of the Discover Diabetes program or similar among younger patients? So I might ask you, Ciara, specifically to take that, if that's okay. And also if anybody else from the team, as I'll call you, the team of presenters, want to pitch in and just referral pathways, because referral has come up a number of times across Daphne and type 2 and different aspects. So Ciara, if I could come to you first on that, please.
Yeah, I suppose a trend in recent years, we have noticed more younger people with type 2 diabetes being referred for self-management education support, and they're absolutely welcome to come along to a program, even though the mean age perhaps in most groups is probably about 60, and maybe we will get to a point where we'll have younger groups. Perhaps, I don't know. Often if somebody is attending an SMES course like Discover Diabetes and they have any other health concerns or any other underlying medical conditions, the dietitian who's delivering that would generally be offering a one-to-one service as well. So that's also available, and that's free of charge around the country as well.
Brilliant. And I should just add to that, Ciara, as well, and something Kathy has flagged in the chat box as well, is that we hosted an earlier presentation back in April of this year, April the 24th, which is hosted on our website as well, which went through different aspects, but including Daphne, just talking specifically about Daphne, but it's got really valuable information on a number of aspects, including the technologies and in terms of insulin delivery, and also dosing of insulin in older patients as well. So just to bear in mind, this is the second of 2 webinars that our colleagues are collaborating with us, so it's fantastic. Does anybody want to talk to the general pathways, or are you happy that you've signposted it in the chat box? As I say, we will capture that, but is there anything else anybody wants to add to in terms of signposting or referral pathways?
Can I just add really
Sure, yep,
quickly,
Assumpta,
Dawn?
thank you.
It's not something I hugely went into. So I suppose our biggest risk in relation to patients living with diabetes is active foot. And by the time that they have a wound or an open sore on their foot, it is really about getting, very quick access. A lot of patients will already be connected with the hub and will already have a signed team member. So I think it's really about, because I am finding through our own practices that they will often go in to collect their medication. They will often discuss their wounds or their issues, with the pharmacist directly. They may ask for dressings. And I think, I suppose that the 2 largest things for me is obviously that discussion that will take place between the pharmacist and that patient. But it's also just about kind of asking, are you connected,
Sure.
with the foot service? Are you connected? Have you spoken to your GP lately? Have you got the name of somebody to connect with? And encouraging them strongly, if they have a foot wound, to get early intervention, because the research is showing us that the larger complications is where they are not accessing service for
yeah.
very, very quickly. They often tend to, especially in areas where they would live a distance away from hospitals,
Yes.
they will depend very, very strongly on their pharmacists to kind of guide them. They will look for the dressings, they will look for the temporary measures, but, because it's a long distance, especially outside of the larger cities. And it is really, about assisting them, but it is about guiding them back to their teams to get intervention early, especially where the wound has occurred. So GPs, hub teams,
Yes,
and
just making a point of contact.
just making that point of contact and encouraging them back. And again, if they do wish to buy products, it's about kind of encouraging them to get products that would be safer for the lower limb and the foot. So, for example, corn plasters that don't contain salicylic acid or acidic in nature, because their neuropathy won't allow them to feel any damage that is actually being done to the skin. So it's about kind of that discussing that kind of self-help, but really encouraging them to access services early for limb salvage and reducing amputations.
Fantastic. Thank you, Assumpta. As you say, the pharmacist often the first point of contact for many of these questions. So I'm really appreciative of everybody's time. I don't want to run over time any more than we have, but that is in no means to cut things short. I might just put up the last slide, Grace, before we say our final farewells. We really appreciate your feedback. So the link to the post-webinar survey has just gone into the chat box. Thank you, Grace. And I would also like to say that I think our colleagues tonight have demonstrated the actual breadth of resources and links and signposting on their website. So I would encourage everyone to, watch the webinars, get the information that you need, and use them as a repository or resource. We will collate all of the links that are in the chat, so don't worry if you've missed them, and we will add them to our website over the coming days as well. And a huge, huge thank you to our colleagues for putting together such a wide-reaching MDT webinar tonight with all the presentations. I think it's just an absolute, credit to all the services that are out there for patients with diabetes, and the work that you're doing in the National Clinical Programme in all your areas of practice. So thank you so much. So that just leaves me to say thank you as well to all who have attended tonight, as I say, on this sunny night. This is actually our last webinar before we head into the summer. So enjoy the summer break, and we will be back in autumn. Please keep an eye on your emails for what's coming up next, and also on our social media posts. Enjoy the summer, stay safe, and enjoy the webinars in the meantime they're back on record. So a big thank you from ourselves here in the IAOP to everybody tonight, and take care. Goodbye.
Thank you. Bye-bye.
Thank you, John.